Well, good afternoon, everyone. Welcome to the final session, which is on clinical researchers as research translators. My name is Peter Ebling. I'm a professor of medicine with the University of Melbourne and an endocrinologist, and I work in the western suburbs of Melbourne. And I think it's areas like the western suburbs of Melbourne where the translation of research findings into clinical practice can have some of the greatest impacts on healthcare of people living in those deprived areas. So I think clinician researchers are really important in translating research findings. And we've heard about the chasm between evidence and practice. But there's also a valley of death for the clinician researcher in their career trajectory. They often do postgraduate training in their specialty. It might be in a specialty of medicine or public health. They do a research higher degree, and then they go overseas and come back. And it's really this stage when they come back from overseas training for a postdoctoral fellowship where they can lose the thread of all that experience of clinical research that we need to support them. And I've been very interested in trying to work out ways of supporting them from a state government level as well as a Commonwealth level. And I think one way is to get clinical researchers to talk to one another, and I think a forum like this is an excellent way of starting that process. But another way is some of the initiatives that the NHMRC has established, and the Centres for Clinical Research Excellence are a particular way of reinforcing clinical researchers and making a new generation of clinician researchers, and I think that's been a tremendous initiative. And we're going to hear an example of a successful Centre for Clinical Research Excellence that's just starting this year. So we've got three outstanding clinician researchers. If you think about examples of clinician researchers, these are really in the pinnacle, and they're going to be talking to us now. And we're going to start, and then we're going to end with the government's approach to public health reform and research translation. How do those two things fit together? So it's a really good session, and I'm glad you've stayed to the very end. So it really gives me a great deal of pleasure to introduce the first speaker, Professor Rochelle Bookbinder, who's Director of the Clinical Epidemiology Department at Monash University, based at Cabrini Hospital. She's also a rheumatologist, and her research has really been groundbreaking, and it's challenged dogma about interventions for pain relief. She's an expert in back pain, and as you heard earlier, she's also the co-chair of the musculoskeletal part of the Cochrane collaboration, and she's going to be talking about research translation from the perspective of a clinician and a researcher. What are the barriers and enablers? So thanks very much, Rochelle.
Thank you very much, Peter, and I'm honoured to be invited to talk at this illustrious faculty meeting. So we all know that changing clinician behaviour in response to credible evidence remains highly challenging, but the problem is not new. And I'd like to show you a short clip which is set in the 1880s, so 150 years ago, where they grapple with a similar problem.
Honestly, that oaf Richardson had his way, we'd perform surgery in the sewer using rusty saws, and it would be Beekman's pills for everybody, no matter the ailment.
Granville, are you aware I specifically told the nurse not to change these bandages?
Soiled bandages are a haven for germs.
Germ theory is poppycock, Granville. Now stop speaking of it. You're frightening the patients.
Poppycock, but Lister has proved it. All the latest journals.
Tripe, Granville. We won't be needing those. Thanks very much. A studied air of calm reassurance and a regular bleeding. These are the keys to modern medicine.
Will you remain calm when the leg putrefies and becomes gangrenous? When you amputate? When the rot spreads to her blood and kills her?
I've had quite enough of your impertinence. Put back that bandage and bleed a pint.
Look at her, man. You'd get more blood out of a turnip.
Do as you're told. And give her Beekman's pills for insurance.
Beekman's pills are rubbish. They will do nothing but bring on stomach cramps. I won't stand here and watch you murder your patients just because you can't be bothered to read the latest science.
At long last, we agree, Granville.
Bloody dinosaur.
So we've heard this morning that there are several ways that people have tried to change clinician behaviour, including some of these things listed here. And we also heard that these have really had, some have had none or just very modest effects. This is a study that I just heard about last week in Denmark. It's looking at imaging for back pain in Norway over the last 10 years. And they've thrown many of those strategies of changing clinician behaviour at the problem. And as you can see on this slide, there's been actually no change in 10 years at all in the proportion of people with back pain who get an X-ray. For people with acute back pain where there's no indication for X-ray, it's actually got worse. And even though they have reduced X-rays and CT, it's been really replaced by MRI scans. And at the moment, we don't allow GPs to order MRIs. The patient pays. So this is an example of what might happen if that were to change. You've also heard from Sally about one of the studies we've done called the Implement Cluster Randomised Controlled Trial. It was Simon French's PhD, where we knew that there were too many X-rays. We looked at evidence-based guidelines. Denise Connor did barriers and enablers research, qualitative researches, and then we used a model of behaviour to try and change clinician behaviour, and then the problem would be solved. However, we used intentions to measure vignettes, and whilst the doctor said they were less likely to order X-rays or any imaging, unfortunately we didn't get buy-in from patients, so we couldn't determine whether it actually changed clinician behaviour. And looking at administrative data, there was actually no difference between the usual care group and the intervention group in terms of the actual numbers of images that had been ordered. So I think it's important to recognise that we're part of a complex system, and with 10 years of multiple strategies to change clinician behaviour, if anything, the problem has probably got worse. And I think it's important to recognise that it's not a simple loop, but it's a very complex system. And some of the things that we do that may actually be counter our best efforts. This is a slide that was developed to look at the challenge of implementing evidence into the workers' compensation arena, and it's no different in general. And much of the focus of trying to change clinician behaviour has been at the attending physicians and other health professionals without considering the other important players. In particular, we haven't heard much today about the patient and their beliefs and attitudes and knowledge, and their carers. We haven't heard much about the workplace, and we haven't heard that much about the system and the factors that might drive change or not. And then there's also the overall cultural context, the political context, that might also either enable or put up a barrier to changing practice for the better. This is a study by Porglasio and Associates looking at the leakage between people who are aware of guidelines, who agree with them, who intend to adopt them, and what actually happens in practice, showing that there's on average, a third or less of guidelines are routinely adhered to, and the rates and patterns of leakage vary depending upon the type of clinical guidelines, so prevention studies or drug therapy. And that the barriers actually vary at each step of the awareness to adherence pathway and depending upon what the guidelines are trying to achieve. This is an old study from 1999 where they identified almost 300 barriers to why physicians don't follow guidelines. And it's important to acknowledge that sometimes they're simply not aware of them, or there are external barriers that prevent them from adopting the change that they know to be right. So I think that more societal approaches may be needed, and I want to share with you an example from it's WorkSafe, but it was called Victorian Work Authority in the late 1990s, who set about doing a mass media campaign in Victoria to try and abate the rising costs of back pain claims, which had tripled over 10 years. And their recognition that it was really impossible to change clinician behaviour. So what they envisaged was a mass media campaign focused on very simple evidence-based messages to stay at work. You don't need an X-ray, you can be active and you don't need to rest. Directed at the general population, which at the same time would also be directed at healthcare professionals, workplaces, employers, everybody, all at the same time. It primarily used television and it had very clever ads directed at different parts of the population. It used actors, local celebrities to get the message across. But as well as that, it translated the back book into 16 languages and made it widely available. And also doctors received a copy of the guidelines, although no one seemed to recall receiving those. But as well as that, there was buy-in from the stakeholders. So all clinicians that have an interest in back pain were invited to the table to agree on the messages. And importantly, the unions were involved, the employers were involved, everybody was involved and could agree on the messages. And at the same time, there was very supportive policy and legislation that would enable improvements to be made. And the campaign was exceedingly effective at changing population attitudes and beliefs, with no change demonstrated over time in New South Wales, which didn't receive the campaign. At the end of the campaign here, you can see that the beliefs were sustained over time. And it's important to recognise that this is when the government changed somewhat by surprise in Victoria, and so no more ads have been aired since the beginning of 2000. The population change was accompanied by significant change in general practitioner beliefs, with them being half as likely to order an X-ray as their counterparts in New South Wales. And the differences again were sustained over time. Importantly, this campaign resulted in fewer numbers of work cover claims being made, 15% fewer, as well as, for those already off work, a reduction in days lost and a significant reduction in both medical costs and total costs. And because of this campaign, it's been replicated in many places across the world. And all have shown these similar improvements in population beliefs. But in fact, only Australia has shown such favourable outcomes in healthcare use and work loss, with no demonstrable behaviour change in other settings. And we've done what's called a realist synthesis, which is going back and trying to understand why things changed or why they did not. And I think that's a very important strategy to use when we're thinking about implementing evidence. And we realised that there were very important differences in scope, in the funding, in the media that was used, but also quite significant differences in the legislation and health policy of those other places that just didn't enable people to change. We looked at a Rothschild model of social behaviour change, where at one end there's public education, assuming that the public will act appropriately when provided with information. And I think for many cases this simply doesn't work. We used a social marketing approach which uses a combination of both public education and law reform to change behaviour, assuming that people lack the opportunity or the motivation. And I think at some levels we need a more authoritarian approach where legislation simply limits or facilitates behaviour, assuming that the public are unwilling. This shows the mass media campaign looking at different population. So it showed that it shifted population beliefs irrespective of the demographic characteristics of the population, their employment, their income, and even whether they'd seen the ads or not, they all shifted to a similar degree. We showed similar things with general practitioners irrespective of their background. But there was one group that didn't change, and that were doctors with a special interest in back pain. And this slide here shows comparing doctors with a special interest to those without a special interest. And this indicates that doctors with a special interest were more likely to think that patients needed complete bed rest, more likely to think they shouldn't go to work, more likely to think that imaging was necessary, and somewhat interestingly, they would not find practice guidelines helpful in their management of back pain, and you'd have to wonder why. And there were no differences between states or over time, demonstrating that these people were the only ones who really didn't change as a result of the campaign. And in that instance, you may need to go with more legislative change. Another important factor that has hindered our ability to change practice in line with evidence is the introduction of treatments before their proper evaluation, specifically non-drug therapies and new technologies. And it's now well recognised that it's much more difficult to study once accepted as standard of care. And there's likely to be opposition to both the conduct of the study and to the results if they're inconsistent with ingrained beliefs and or vested interests. A good example of this is a study that was just published in the MJA, showing that there's been absolutely no reduction in the use of arthroscopy for osteoarthritis of the knee for the last decade, despite compelling evidence from at least 3 placebo-controlled trials and 2 Cochrane reviews showing a lack of benefit, and observational studies suggesting some harm. So this is one instance where you may need more legislative change. We know in the last decade that there was a significant rise in vertebroplasty use despite the lack of any randomised controlled trials. In 2009, there were 2 trials, both showed no benefit over placebo, and this was followed by a pooled analysis which showed no benefits for subgroups that were thought to possibly might have benefit. And this has led to ongoing debate and ongoing attack with editorial headings such as the ones shown on this slide, bad news or sham news, and vertebroplasty evidence and professional protest. However, there have been some changes with withdrawal of reimbursement in some parts of the US and Canada and removal of an item number at the end of last year. And some guidelines have now come out strongly against the use of vertebroplasty, particularly being confident that future evidence is unlikely to overturn the results. But the main people who do these procedures continue to recommend for their use. I think another thing that's not been touched on today at all is the role of the media. And this is an article that was published in the Australian Financial Review by Jill Margot in 2004, talking about an almost miraculous treatment for a particular form of back pain caused by osteoporosis, demonstrating that the media tend to overstate the benefits and ignore or downplay the harms. They like breakthroughs, and they've certainly failed to report conflicts of interest. And I think that something has to be said for involving the journalists and media in our efforts to try and change evidence. Jill Margot published a follow-up article, not acknowledging that she'd written a previous one 6 years ago, suggesting that it may not be wise to introduce treatments before they're properly evaluated. We're also bombarded with many misleading claims for advertising, both television, books and the internet, and I wonder whether there's a way that we can address this problem, because this confuses patients and also hampers our efforts to practice more evidence-based medicine. And something that hasn't been touched on, I think it was touched on in one of the questions, is are we doing the wrong trials? I think there are a lot of trials that are being done where the answer's actually already known and further studies are unlikely to change the status quo. Or the question may be unimportant, and methodologic flaws mean that the answer's unlikely to be valid. This is an example from back pain trials where there are 118 trials that were reviewed showing that irrespective of whether you got the treatment or the control, your response to treatment was exactly the same, indicating that specific treatment is actually irrelevant to the recovery of back pain. Yet, when we look at the clinical trials registry, I found 40 new trials being done for back pain last year. Many of these treatments we already know don't work or have very modest benefits. There wasn't a single trial of translation into practice studies. And so I think we need to redirect the research effort. This study looks at, over the last 10 years, how many implementation studies have been done over a variety of treatments in the last 10 years. And there's been scarce studies, and they're not increasing in number over time. And importantly, they pointed out that clinician participation rates were particularly not very good. And again, that was raised in the question time about the clinicians' motivation to change. And just as an example, this was the Implement study. All GP practices in Victoria were approached, yet only 5% of practices agreed to participate and only 2% of GPs agreed. In fact, when it came down to it, only less than 2/3 of people actually attended the workshop. And follow-up was 1 in 5 GPs didn't complete follow-up. So this is really something where we need to increase our efforts, and perhaps we need legislative changes to compel clinicians to be involved in implementation studies, and also to compel patients, because as I've said before, we couldn't get patients to participate at all. So in summary, I think that the clinician practitioner can do a certain amount, but we certainly need some help. And I've decided that I probably need to change my employment status. In summary, we know changing clinician behaviour is difficult. We need to consider the broader societal context. We need to ban introduction of new treatments before their evaluation, address competing interest and misleading claims. We need to improve the understanding of evidence principles and buy-in from all, from the general population through to clinicians. And we need funding for the right trials. So I think that getting evidence into practice is possible, but I think that all the planets really need to be aligned. Thank you.
Thanks very much, Rachel, for that wonderful talk. Now, it gives me great pleasure to introduce our next speaker, who's Professor Anne-Louise Ponsonby. Anne-Louise has got a medical degree, she's also got an MPH and a PhD, and she's been very active in the area of early lifestyle environment and the effect of immunity and autoimmunity. She's also been very active in the area of vitamin D and its relationship to multiple sclerosis. But today she's going to give us an example of a successful Centre for Research Excellence, lessons learned from child asthma and plans for paediatric food allergy, how Centres for Research Excellence translate research into practice. So thanks very much, Anne-Louise.
Thank you, Peter, and thank you for the opportunity to speak today. I must say, Peter and I first met at a translational activity, so it's rather ironic that we're meeting here today. And I thought that perhaps something useful I could do as a long-term public health physician is sort of contrast some of the old work we did in relation to child asthma with some of the newer work that we hope's being facilitated by the CRE approach in food allergy. So I'll start off more than a decade ago, where we had a burning desire to look at infant bedding and asthma. We just finished the large cohort study in Tasmania for sudden infant death syndrome, 10,000 babies, and we had an extensive amount of infant bedding data, and the children, when they got to school age, were followed up for asthma and lung function. So it was a fairly internationally unique data set, and at that time childhood asthma was quite a public health problem. To undertake that at the time, it wasn't really classically fitting into an NHMRC structure. So we probably spent over 6 months back and forward with the Commonwealth Department of Health and Aged Care, as it was called then, speaking with various bureaucrats about why it might be useful to have an investment just in analysis of that cohort. And in 2001, we were awarded that amount. And then from 2002 to 2005, we published quite a bit of work, you can see down there on the right-hand side, about moisture-trapping bedding such as synthetic quilts, pillows, sheepskin, infant cocoons associated with a higher risk of asthma. And we also demonstrated that home environmental conditions could potentiate adverse effects. And this was hopefully useful data from an observational cohort rather than an RCT, because we were looking at the interaction of home environment factors in a way that would have been difficult in an RCT design. And as you can see, for the infants that had extensive house dust mite rich bedding and who had environmental factors such as recent room painting, then their odds ratio for asthma was high at about 14. So the National Asthma Campaign had been set up by the Department of Health and Aged Care at that time, and it had initially had a very clinical focus on better treatment of asthma and better asthma management. But we then developed a more environmental side, including some of these sort of pamphlets for health professionals and hospitals and so on bedding. So, you know, we now know that use of sheepskin and that sort of bedding for newborns is much less common. The second asthma issue was the indoor air quality and asthma issue. I'm talking from a personal perspective because I think it's actually something quite useful, hopefully, to bring to a session like this. I mean, you know, I think the systematic approach is fabulous. We all need that, but sometimes the personal anecdotes sort of are useful for translation. So we moved on to looking at indoor air quality, and similar findings were being reported elsewhere. The New South Wales State Department of Health was particularly interested in translation in that time, and I think one of the issues for government that was a driver was the schools. We actually were, as a government, setting up a certain type of school environment for children. And I think the onus was greater to try and get that right because the government didn't want to be facilitating harm in any way. So they set up a council called the N Health Council with the Department of Health and Ageing. Note how a lot of the work is coming from the state and government departments back in the early 2000s with translation. And they would invite various individuals to come in on a government panel and work on documents. And it took, you know, quite a long time before the work was internationally referenced. So it's 2005. So, you know, we've got a half a decade there, and I'm going to contrast that with this sort of CRE structure in modern. But nonetheless, there were some reductions in the non-ducted gas heater use, and the proportion of children exposed to tobacco smoke was particularly noteworthy, and that's been documented by the Australian Institute of Health and Welfare, from 31% in 1995 to 8% in 2007. So it's a great thing to see. So here's a photo of children in a New South Wales school. It could be a school in any state in Australia, but to see the unflued gas heater, the fact that was one of the big drivers to do translational work in this area, the fact that we were actually administering something that may not be wise. And of course that was followed by the Asthma Friendly School campaign, and it's quite a different situation in schools now. Now, I'd like to contrast those two environmental initiatives, which in a way are a little bit broader than a clinical trial. So in 2003, Nick Glasgow's group published in the British Medical Journal that if general practice was structured with 3 proactive reviews for children with moderate to severe asthma, then the number needed to treat to benefit in terms of a hospital outpatient attendance for a written asthma plan was 5. Pretty impressive number. And that project, because it was automatically already part of general practice in Australia, was quickly changed to policy and practice. So it was published in 2003. The plan was implemented in 2003 and 2004 through the Practice Incentives Program. So very quick turnaround, and it continued to be supported by asthma foundations, community support, and it's still currently funded by Medicare. And that was sort of an easier area to translate because the structural work was already set up and under Medicare control, and it just needed adjusting. Okay, so We had, as most of you know, that in asthma we have had a decline, particularly in the youngest children in hospital separations for asthma, and the beach study and so on show for general practice attendance as well. And that happened over the late 1990s to 2000. One of our missed opportunities here was that we didn't have a database where we could easily look at changes in risk factors over time, so we could try and work out how much of the asthma rate drop was due to any of those three issues I've mentioned, or whether other factors like reverse cycle air conditioning becoming more common in homes were more common. And I contrast that to the sudden infant death syndrome work, where we were funded by NIH to look at the SIDS rate drop, and we could attribute, 2/3 of the rate drop seemed to be attributed to changes in sleep position, 10% to changes in improved thermal care. And, as time's gone on, it's been really good to have that information, and it was an opportunity we did try, but we weren't able to achieve with asthma. Okay, so while the asthma rates were pleasingly going down, we had this other new epidemic rising, which was food allergy. And this graph shows Australian anaphylaxis fatalities and admissions in Australia, and how they've increased from the mid-90s up to 2005. And this graph here is just showing admissions, but if we just show you, we've had an increase in the food anaphylaxis, and also an increase in anaphylaxis in relation to other things such as insects, stings and so on. So what's happening now is we know there's an incredible amount of activity happening in the community. I mean, you just walk down the supermarket, there's gluten-free products, there's labelling, there's schools that won't let children bring any peanut butter to school, there's natural therapy groups trying to cure food allergy by different types of probiotic therapies, and there's a huge amount of community interest on this food allergy issue. But prior to the CRE that has recently been awarded, none of that activity was coordinated, and it was across a range of different groups. So we had, say, Katie Allen, who's the lead investigator with the CRE for food allergy, working with industry as a lone clinician to help with, regulations on food labelling and so on. Or we had various individual journal article publications, such as this one, where possibly early introduction of egg can help prevent egg allergy. And again, we've got sort of Jennifer Copland and the rest of the team at Murdoch, including Katie and myself, sort of making individual or small group submissions to NHMRC on their draft document for infant feeding. So again, a bit of a piecemeal approach, a bit like, some of what happened with asthma. And meanwhile, we have a lot of different organisations giving infant feeding guidelines out, and NHMRC had some guidelines in 2003, and they're currently revising the latest guidelines and inviting comment on that. So, against that problem, and with the National Asthma Campaign in mind, we hope that the clinical investigator team, which consists of equal weighting for clinical and public health expertise, will help us to manage the response to food allergy better. The larger associate investigator team provides clinical and academic expertise in areas such as nutrition, allergy, gastroenterology and general paediatrics, and it provides the national framework. And we're looking at food allergy, but we're also looking at food-related immune disorders, some of them of which are poorly characterised, and it'll be difficult for a single individual project to do that. But a CRE allows us the opportunity, hopefully, to get a better national perspective on that. So the overview of the CRE, we have in the research stream 4 observational cohort platforms that are already existing and funded, and then stream B we have randomised controlled intervention studies that I'll come back to. In our transfer phase, we have got a set of research questions. One of them is on infant feeding, and in fact that'll be our first systematic review to help inform national policy. Then we have development of national databases and community management, including working with the education department, not on a state level as previously been occurring, but now hopefully in a nationally coordinated way. Then we have education and training, which is not only going to be restricted to people with food allergy expertise, but also to all the groups who manage children who may be affected by food allergy, including teachers and so on. And then we have public policy and practice. We have a part-time knowledge broker working as part of the CRE. It's a very content-deep area, and there is a lot of knowledge transfer we think that will be required. And then we have these collaborations within a management structure, not just with our national research groups, but also our international groups. So we're hoping to move in parallel with some of the other groups like the World Allergy Organisation and so on. And of course in Australia, the Australasian Society of Clinical Immunology and Allergy, which has previously done a lot of the translational work in this area. So I'm sorry this is a little bit small, but just to take through some key points. So criteria 1 in the CRE is generating new knowledge. As I've said, we've got the cohort studies, but here we have 6 NHMRC funded RCTs. So in contrast to the asthma example, there's a level of coordination amongst those where we're trying not to replicate things that are already in way, and we're hoping to build on them to have some nationally based RCTs for primary and secondary prevention of food allergy. Effective transfer of research into health policy health policy and practice. We're going to work closely, as I've said, with the Australian Society for Allergy and Clinical Immunology, and one of our first translation projects will be this systematic review to help inform infant feeding guidelines with NHMRC and other groups. Foster and building capacity in the health and medical research workforce. We're trying to develop capacity in conducting high quality research, but also in the skills required to translate research into evidence-based clinical practice and community activities, and facilitating collaboration. We have this more modern link where we're trying to work internationally as well as within Australia. So I sort of see what's happened over time is hopefully the CREs provide an opportunity now where we have a much more integrated, coordinated agenda. We have the opportunity for things to happen at a slightly faster pace because we're working in parallel with international groups. And I'd just also like to mention that, you know, the state departments of health and the government departments have previously, you know, supported a lot of this translational work, and I hope they'll be working with NHMRC in that mode as well. Thank you.
Thanks very much, Anne-Louise. Now, it's my great pleasure to introduce our next speaker, Professor Catherine North. For those of you who don't know, Professor North is now at the Institute for Neuroscience and Muscle Research, which is based at Westmead in Sydney, but she's been appointed as the director of the Murdoch Children's Research Institute here in Melbourne. So unfortunately, she's got to make the difficult transition from Sydney to Melbourne, and we were discussing that earlier this morning. But she's also head of Research Council at the NHMRC, and she's very interested in the role of the NHMRC in supporting clinician researchers. So thanks very much, Professor North.
Thanks, Peter. Today I'm going to talk in two phases. First of all, I'm going to wear my hat as a clinician researcher and talk about some of the challenges that face clinician researchers and how we should perhaps approach those. And then I'll change hats to talk as chair of the NHMRC Research Committee in terms of funding and what the NHMRC is investing to try and encourage more clinicians to do research. So, I think there'll be many of you in the room who have faced the challenges and the delights of being a clinician scientist. And it struck me in our first talk today, or the second talk actually, that these knowledge brokers, that was a mysterious term to me until earlier this year, that clinician scientists can often act as the knowledge brokers within the health system because you speak the language of research and often of basic laboratory research as well as the clinical language that you need to talk within the healthcare system. And so as there is an increasing emphasis on translation, which is what we've been talking about today, it's increasingly valuable to invest in the clinician scientists because really they are the people, hopefully, who can make these things happen. I think, though, that the pathway to becoming a clinician scientist is not easy. It's very long and lengthy training, and there's definitely a financial burden. So I started, for example, I did a 6-year undergraduate medical course with a BSc Med in the middle. I then did my internship, basic training, my fellowship exam. I did advanced training as a neurologist, as a geneticist. In the middle of there, I did a doctorate. Then I went overseas and did a postdoctorate. And then I came back and got my first job when I was 37. So that's a very long haul, and I must say in the olden days when I was doing that training, I'd never heard of the NHMRC. It was this thing I heard of when I came back from overseas, and that I didn't have a track record in the NHMRC because within a hospital setting, often when you're being instructed by clinicians that are not involved in the currency of research, they don't understand how important it is to build up that track record along the way, and it's something I know that I really try and transmit and encourage young people to do as they're doing their degrees or getting involved in research, is you've got to start building up your track record from an early age. The other thing, though, is that when you're looking at clinicians who have done medicine and are doing training and often subspecialty training, when you go into research, and most of the people I know who are clinician scientists or academics become addicted to research. It's people say to me, it's something I could not imagine not doing research as part of my career and part of my everyday. And that's lucky because, it sucks really that you're paid, the most talented and smartest people are paid a lot less than their colleagues who've done a lot less research, a lot less lengthy training. They've got an intervention, so they get a lot of money. And it's sometimes for me quite hilarious when I'm sitting there in my current job as, I'm still in Sydney, as Professor of Paediatrics, and I'm talking to, these wonderful surgeons that are interested in doing research, but are really, they're not happy to take what is about 3 times my salary, take that cut to about 3 times my salary to actually put aside some of their time for research. So the discrepancy is quite marked, and you have to have quite a thick skin and decide that that's what you're going to do anyway. And I don't see any way around that. The second thing, just apart from that financial burden, is that you have to often apply for your income. It's every 5 years. It's not set. You don't get that sort of, the tenure of a staff specialist. And it really, really cheeses me off that my husband, who's an emergency physician, gets $37,000 a year study leave and travel payment. And I, as a University of Sydney academic, get none. So apart from that, it's really great being a clinician scientist. That was my whinge. The other thing about being a clinician, no, I've got more. In terms of medical training as well, I mean, I did, during my medical training, 18 months in the neonatal intensive care nursery. I did 9 months in cardiology, and I ended up as a neurogeneticist. And during that time, it's very bare in terms of publications. And we all know, you know, with a 17% success rate for the career development fellowships, for the 20% success rate for the project grants, you start behind the 8 ball compared to someone who's done an undergraduate degree, honours, PhD, postdoc, and been pushing out the publications ever since. That's the end of my whinge. Because I think that actually being a clinician scientist does make you a better doctor, and we've heard so many examples today of the application of research into clinical practice. And I think that in turn is very rewarding to a patient. And certainly within my clinical practice, which is in neurogenetics and particularly neuromuscular disorders, at the end of the consultation, the fathers, it's always the fathers, say to me, "Doc, how is the research going?" And they've done an interweb search, and they want to have a good chat about what's out there, but they want to be involved. And so patients are very engaged in research. They get a joy out of people working on the thing that is happening to them. We get like 95% participation rates in our clinic in various clinical trials and clinical studies that we're doing because they really appreciate that all of their doctors are involved in clinical research. I also think the clinician scientist as knowledge broker and as educator can speak and communicate well because you get to practice on your patients every day. You have to explain, well, I have to explain complicated genetic concepts to people from the west of Sydney, and so that they get it and so that they understand. And I think that's incredibly important, both from an education, from the media, in terms of lay people and trying to engage people and trying to get money out of them. I think that's incredibly important. So what I think we need, and I'll come back to this because I think this is reflected in many of the proposals that have gone up to the McKeon Review, is that we need more clinician scientists, and we need them working alongside basic scientists in partnership in our research institutes and our universities, and we need more clinician scientists in our teaching hospitals, particularly the tertiary and quaternary services where we can do this translational research and particularly get clinical trials going. And there certainly needs to be an increased focus on research and clinical trials in the hospital setting. And I don't know about you guys, but I find that my hospital pays lip service to the value of research, and it's very hard to get them to put their money where their lip service is because of the very tight budgets in so many other areas, and research is seen as a bit of a luxury that's often the first to go. So it's not a supportive environment for research, and I think that's probably, to me, is the major difficulty we need to overcome in terms of really getting to true translational research. It's got to become part of the hospital system. We've got to engage the state governments that are funding many of the hospital systems to make this happen. So I'm now going to switch and wear my NHMRC hat, and I'm going to skip through this because I think most of you will have an idea of this overview, but I think it's very important that you get a comprehensive view of where NHMRC is investing in terms of the clinician scientist and clinical research. So for the next strategic plan that Warwick talked about earlier today, certainly the NHMRC is, as we are today, providing leadership to get research translated into clinical practice, but still not neglecting health discovery research. I mean, I still think an incredibly important part of the research that is funded is investigator-initiated discovery research, but I think the two go hand in hand. I think I will also focus on this last part here, which is working with the partners, the states and the territories, and We joke with Warwick because he's going on his royal tour of the states to engage the state governments, and certainly on NHMRC Research Council, it's really good to see that the chief medical officers of each of the states come to Research Council, which is every 2 months. And I hope that that's going to be an avenue where we can really push the states to be investing in the hospital systems in each state to start supporting research more, because I think that's the only practical way that it's going to work, and how we're going to take some of the burden off the NHMRC, the financial burden of actually pushing more clinical trials into the hospital setting. NHMRC funding schemes, Anne Louise has given us a beautiful example, of the CREs and how they work. I think the CREs are a fabulous initiative that's just been over the past couple of years. There's been 22 CREs awarded, and there are 2.5 million. But they really provide leverage and infrastructure to get other funding in an area. And also there is a focus on bringing different centres around Australia together. I think the other thing that's important about the CREs is, as you go through what they're looking to fund, they really want to educate the health and research workforce and provide the researchers of the next generation. Certainly that's a big focus. And because of their nature, that is involving training young clinicians. And certainly I think the CREs are a very good way of doing that. The program grants have tended to be not particularly focused on clinical research, but I think the benefit of them is that they're a 5 years duration, and that increasingly there will be a clinical research component to program grants. I think as there is an increased emphasis on translation, most programs in different disease-specific areas are going to have to demonstrate a partnership to actually promote translation into clinical practice. And I think increasingly that's becoming one of the criteria on which research is judged. Certainly the program grants, I think the 5 years duration is a great benefit, and I know that within NHMRC and within Research Committee there will be a move to push people more towards 5-year project grants as well, because I think research does need to be funded for longer periods of time. Warwick's also mentioned the partnership projects, and I think the good way to think about these is they're like ARC linkage grants, but they are for medical research. And I think really people should be looking at this particular avenue for getting funds in partnership, whether it's with lay organisations that are working in your area, whether it's with state governments, people that are invested in a certain area that can help provide funding in kind. And so, these are really, really focused on the relevance and likelihood of influencing health and research policy and practice. So these are very translational, and I think a relatively new initiative, but very much focused on translation and improved health outcomes. People support, you all know these, but I think the one thing I'll point out here in terms of postgraduate scholarships, the NHMRC this year, I'm sure you will have heard the screams down the corridors, has changed the rules so that they are actually much more weighted now towards encouraging clinicians to apply, because from the biomedical point of view, you need to be 5 years post an undergraduate degree to apply for the NHMRC postgraduate scholarships. The APAs are much more now for people coming straight out of science degrees. And I think that does provide a bit of bias towards encouraging clinicians to apply for these scholarships. Early career fellowships, I do think that the success rate often for people with a medical background or clinical background, there tends to be a good success rate. I think really quite the success rates for fellowships are generally dire because of the funding situation in Australia and worldwide, but I still think that there are a good proportion of clinical fellowships that are supported. Practitioner fellowships are really supporting the top clinician researchers, and they can be done part-time, acknowledging that people have their clinical practice, but the aim is to provide protected research time. And these are, again, as with all schemes, highly competitive, but really, again, focused on supporting the clinician scientist. The TRIP, or Translating Research into Practice fellowships, are also a relatively new innovation, and they are also focusing on research translation. So these are schemes which, when you've got people with excellent track records that are really working in the research translation area, that these are particularly good fellowships. So just to finish off, this is not what came out last Friday, but the year before, but I think the percentages are relatively similar for the grants starting in 2013. The overall success rate for project grants for 2013 was just on the 20% mark. And so the overall, the NHMRC, I think we awarded $690 million last week, and program grants are still to go. Of these, there has been an increase, if you look over the last 10 years, of investment in the areas of clinical medicine, unfortunately a little bit at the detriment of biomedical research, but there's been certainly an increase of about 9% in support of grants in the broad research area of clinical medicine over the past 10 years. As well as, it's smaller, but in terms of health services research and public health research, again, an increased investment. Jump over that. So I'll just finish off in terms of the strategic review of health and medical research, and the NHMRC, and many of you will be involved in various submissions to try and look at what's going to happen to the future of research. And I think that there is, we are in a tight financial situation, which is, as everyone knows, is worldwide. But I think also from the NHMRC point of view, we have experienced a period where there was quite marked growth with a doubling of the NHMRC research budget, but we're now at a point where that budget has not grown and is unlikely to grow over the next couple of years. So we need to look at using our research dollar as wisely as we can. The McKeon review is an opportunity, but who knows? It takes the government then to act on recommendations for there to be any change. And we know from the news this week, in terms of budget, are they going to be likely to invest a lot more into the pot of medical research over the next 12 to 24 months? Unfortunately, I don't feel particularly optimistic that that's going to be the case. But hopefully the recommendations from the McKeon review will help some of the dollars to be spent more wisely. I think in terms of the clinician scientists, that we really need to be all working together to talk to state government, to talk to our hospital executives about trying to invest more in research. I think that there's increasing costs with clinical trials. We can leverage money to do more clinical trials within the hospital setting, but it's going to take too much of the NHMRC budget, I think, to continue to expand to support very large clinical trials in terms of spending millions and millions of dollars on single trials. So we really need to review of how we're going to increase that translation and how we're going to pay for it. It's the question I asked earlier today is that one of the major impediments to research translation is the cost of implementing some of the new discoveries. And I think that probably that's one issue that unfortunately we don't have an answer for, but I think the NHMRC is dedicated to at least trying to make the research dollar go as far as it can. Thank you.
Thank you very much, Professor North. Our last speaker in the session is David Butt, who's Deputy Secretary in the Department of Health and Ageing. He's going to be talking about research, translation and health reform, and he's very well placed to do that. He's responsible for the National Primary Health Care Reform, Population Health and Regulatory Policy and Governance with the Department of Health and Ageing, but also has a background as CEO of the Australian General Practice Network, the peak national body for Australians' division of general practice and state-based organisations. And he also was the CEO of ACT Health and Community Care, and for 2 years was chair of the Australian Health Ministers Advisory Council. So he's got really extensive links with government, and we look forward to his talk today. Thank you very much, David.
Thanks, Peter, and thanks to the NHMRC for the opportunity to be here today. And I wanted to start by actually congratulating Warwick and the NHMRC on this initiative, because I think the research translation faculty is a very important part of the overall national health reforms. I mean, obviously, as has been mentioned quite regularly today, I mean, the issue of translation of evidence into policy and practice has long been a vexed issue, and Warwick is saying it's an idea whose time has come. I actually would go a bit further and say it would be rather negligent or indeed derelict in our own duty if we were not to indeed be trying to take action to improve the uptake of evidence in what we do in healthcare in Australia. And I think most of the community actually would think most healthcare is delivered on the basis of the best knowledge available. It would be very interesting for them if they actually knew the facts. So a very important part of our national health reforms, and I do want to just spend a little bit of time explaining the reforms because they've probably been a little bit confusing and obviously a lot of politics around them. Where it all began was actually establishing the question about what problems are we trying to solve, which I think would appeal to all of you. And it is an interesting thing because obviously we have a generally healthy population, but generally often hides a lot of things because there are severe inequities in our Australian health system in terms of outcomes for particular populations and individuals, particularly Aboriginal and Torres Strait Islander people, people on lower socioeconomic status and people in rural and remote areas. So we do have a complex, confusing system and hard for people to navigate, and lots of barriers, gaps in it, which are created by some things that are strengths in the system, but some things too that are, do create barriers, such as the differences between Commonwealth and state roles and responsibilities and private and public and non-government organisations. So overall, I mean, the first focus in the reforms was about improving access, reducing inequities in the system, reducing those barriers, silos, achieving better health outcomes for the Australian population, trying to have a much stronger consumer-centred system where you had greater participation by consumers in their own care. Looking at safety and quality of the system and things like health literacy, self-care and so forth. But that was underpinned by some real hard drives for change which were related to more issues about effectiveness and efficiency of the system, and certainly transparency and accountability for the expenditure of large sums of money and what indeed were we achieving for that expenditure. And very fundamentally, it was about sustainability, recognising that if the states continued to spend money on the health system in the way they do, particularly with their focus on acute hospital care, then the states were going to be spending all of their money on health services by the year 2035. Obviously not sustainable. So we're also operating, of course, within at the time of original health reforms, we seemed to have a bit of money around. We certainly don't at the moment, and I think it's important, and that's what Catherine was just touching upon, to recognise the environment within which we're operating. We've obviously got environmental change happening in relation to ageing of the population and changing roles within our workforce, the ageing of the workforce, changes in science which are making a whole range of new treatments and cures available, sometimes at expense but sometimes very cost effectively. And of course disease patterns changing at the same time, so we had a system that was developed with a strong focus on episodic care, moving into a situation where we're dealing much more with chronic disease management, and our system hasn't really changed adequately to have the right drivers in place to have the incentives in place to actually deal with that properly. So we the reforms came from a basis of a range of very important principles about what we wanted to achieve, but then got into the area of Commonwealth-state relations and certainly a pretty strong debate about dollars and who controls what. So what went into COAG wasn't what came out of COAG. There were changes that occurred along the way in terms of the negotiations that occurred and the deals that were done. But even then, I think, for the national reforms, for what's been a fairly substantial injection of additional Commonwealth money over their forward estimates, we have actually achieved quite significant and important changes and in what is an ever-changing system. And of course, part of that was moving to activity-based funding, so an efficient price and the establishment of the Independent Hospital Pricing Authority to drive that agenda. Warwick touched on the National Health Performance Authority, and I think that's actually one of the most important reforms of the whole thing, because ABF, the National Health Performance Authority, both of these things give us greater transparency and accountability for what's happening within the system. The National Health Performance Authority is going to be producing reports on the performance of hospitals, both public and private, and it's also going to be producing reports on healthy communities based on Medicare locals, which I'll come back to. But a lot of those healthy communities reports are going to, for the first time, give us contextual information about what's occurring at a local level, what's impacting on the health of populations. Some of it will be about access to health services, a lot of it will be about social determinants of health. And I think these will be very powerful tools for the community to say, well, why is our community not achieving as good health outcomes as other communities? It'll take time before we get that level of knowledge, but it's going to be very, very, as I say, powerful information. Another important part of it, of course, was the establishment as a statutory authority of the Australian Commission on Safety and Quality in Healthcare. And I think, again, there's obviously strong linkages there. The Commission, the health ministers have endorsed the 10 accreditation standards for Australian hospitals, both public and private, which come into place next year, and that's been a very important bit of work. They're moving on to establish now accreditation standards for primary healthcare. It will probably take some time because obviously primary healthcare is an extraordinarily diverse area. But again, it's going to be a very important part of what they do. Their latest strategic plan, business plan, includes now a focus on variation. And obviously there is always going to be variation in terms of treatment, approaches to healthcare, but where it's unwarranted variation. And it's quite interesting. Just there's an OECD study underway at the moment, and the Commission is leading Australia's involvement in that OECD study of variation between countries, and it'll be then moving on to look at variation within country. But one of the examples, prostatectomy, Australia and the Swiss have the highest rates in the world, and our rates are twice what New Zealand's are, so that's interesting in that sort of variation. Even within Australia, in New South Wales, if you look at chronic disease management and the variations that occur in things like asthma, diabetes, COPD, there are variations of 3 to 1 between local government areas in New South Wales, and again, why is that occurring? Other reforms, Health Workforce Australia, to look at the models of care going forward and to look at things such as what's the mix of workforce, what's the scope of practice that we should have, do we need new roles in the Australian health system, recognising that we're going to have a shortage of doctors, massive shortage of nurses, who else do we need to use to actually provide the types of services that we're going to be providing to the community in the future. E-health is obviously a huge area for us, and the personally controlled electronic health record has been somewhat maligned at various times, but in fact it's going to be a fundamental part of going forward, and what it will enable us to do in terms of data and knowledge and ability to tailor treatment to the needs of individuals and populations will be actually superb as the years go by. And a range of other things happening in relation to technology, the NBN, National Health Call Centre Network, telehealth and so forth, and the opportunity to actually move from a reactive approach in a lot of those things, but to more of a proactive approach in relation to prevention, early intervention, home monitoring and screening and so forth. A strong focus on prevention and the National Partnership Agreement on Preventive Health and the establishment of the Australian National Preventive Health Agency. We've had a very strong focus, which is well known worldwide, on tobacco control. That happens to be one of my areas of responsibility, tobacco plain packaging, which is actually a lot of fun. It's quite interesting though, because we won the High Court case, which means that tobacco plain packaging can't be stopped. It goes ahead from 1 December. The plain packaging packs are already being delivered to stores around the country, being sold. We are being challenged internationally, of course, in two areas, and one is the World Trade Organisation, and I've been going to the WTO for negotiations with other countries about that. One of the interesting things is that the High Court case in Australia rested on our constitution. The World Trade Organisation case will rest on the evidence. It will be about whether what we're doing is justified in public health terms, because you've got a let-out or a loophole, well, not a loophole, it's an actual provision in the various trade agreements that we have for public health purposes, but is what we're doing justified or is it unjustified, and therefore it'll be a very strong focus on the evidence. And of course we've touched on the various things going on about the McKeon review, various policies being developed in a whole range of areas in relation to primary health care, mental health and so forth. I tend to look at the reforms at two levels. One is the national reforms, and they're the national ones. Then you've got the local ones, and your two main local reforms are your establishment of local hospital networks and primary health care organisations or Medicare locals. We've got 136 local hospital networks in Australia, 86 of them in Victoria, which I'll leave with you. And 61 Medicare locals, and the principles of those local reforms are all very much about devolution, about local people making local decisions about local priorities, what's best for their community, taking into account, that there will be variation, so you need different responses in different places, but very much ensuring accountability at a local level for that. And I talked variation before about practice. There'll be variation between local hospital networks and Medicare locals. Some are grasping it and running with it, others are actually going to be a bit slow on the uptake. But even since 1 July, when I've seen the establishment of local hospital networks in various parts of Australia, you're actually seeing some of those organisations really running with it and seeing the opportunity, and particularly seeing the opportunity to work with Medicare locals with a focus on prevention and hospital avoidance. I do think the Medicare locals primary health care organisations is probably the most exciting area of reform and greatest potential. If you think about the Australian health system, we've had hospital systems for a long time, whatever they might be called over the years. We've never had a primary health care system. We've actually had lots of different silos. What we're trying to do with Medicare locals is create a primary health care system. So we have unashamedly built them upon divisions of general practice, because we see general practice as very central to primary health care in Australia, but they are broader than divisions, because divisions were very much about managing projects, practice support and so forth, coordinating, integrating general practice, getting larger general practices, doing chronic disease management, getting into some service delivery. But they were very much project managers. This is about having system managers who are going to look across the Commonwealth and state responsibilities, public and private sector, do coordination, integration, population health planning, identification of gaps in services, how do we best fill those gaps. And I think your comments about comparative effectiveness research is very relevant to that. How do they actually select priorities? You can talk about allocative efficiency, but when you actually start getting into allocating, it's very difficult to pick one priority over another. So Medicare locals, they're going to start small, build up over time. They need to build capacity, competence, and most of all, they need to build trust in their ability to actually deliver and make a difference. They will have a strong focus on prevention, and Australian Institute of Health and Welfare estimates about 700,000 people are potentially avoidable hospital admissions each year. So they'll have a strong focus on the interface with the hospital system as well. Very much, as I say, about integrating and coordinating services. They won't control all the levers, but no one in Australia actually ever does. So it's very much about how do they coordinate with other organisations, and often it's about planning together, working together, having like-minded view about what you actually want to do to improve the health of the population. Overall, the goal is to reorient the Australian health system to shift the balance away from our strong focus on acute hospitalisation and more towards that focus on prevention, screening, early intervention, so forth. And we know very much from the evidence around the world, from whether it's from Barbara Starfield or World Health Organisation or a lot of the research that went into the National Primary Healthcare Strategy, that we can get much better outcomes in terms of greater satisfaction at lower cost and better outcomes in relation to the health of the community by focusing on a strong primary health care system. So, World Health Organisation found, for example, that where countries at the same level of economic development are compared, those organised around the tenets of primary health care produced a higher level of health for the same investment. And, you could quote Barbara Starfield or a range of others in that relation to that. So, where to from here? We've got, in many ways I've talked about structural and financial reform, and about certainly on the focus of some of those organisations like the Commission on Safety and Quality on the type of outcomes they're going to achieve. Medicare locals, local hospital networks are really a vehicle to achieve an end, and it's very much about where do we take them, so how do we build upon the structures that we've put in place. And if I focus particularly on primary health care, we've got a national primary health care strategy. We're now finalising a national primary health care strategic framework which says, well, how do we take the strategy and then say what are the next steps, what are the building blocks we need to put in place. And coming out of that, which has to go to Chief Ministers in December, I've been chairing a group across Australia that's been developing this. Certainly it's got a strong focus on looking at the social determinants of health and therefore the broadest view of primary health care, and that obviously does mean a lot of intersectoral action that needs to be put into place across the country. But I think I didn't catch the whole of the previous session, unfortunately, because I had to be out of the room, but I did come in and hear someone mentioning about, are we going to start barcoding people, which I thought was very interesting. I thought these days you'd talk about chips in the forehead or something at least. But very much, I think, if you look at what we're trying to do in primary health care, one of the things that, just picking up on that question, is that we are moving more and more over time, I suppose, and there's certainly strong support from the Royal Australian College of General Practitioners and a range of other organisations for moving towards patient-centred medical homes, which has shown to actually have a good impact on the health of individuals and communities because of the fact that you've got an accountability between a general practice and a patient for ensuring they get the care they need, they get follow-up, they can get looked after over the phone, so they get actually good access. You've got a very strong accountability, and those systems are very much based on enrolment or registration. I mean, New Zealand's got voluntary enrolment, 98% of the population's enrolled, and it's an interesting thing talking to a very senior, prominent GP last night who was saying to me, he was just over in New Zealand, and he was talking to the New Zealand GPs who were saying to him, so do you look after your diabetic patients really well? And he said, I give them first-class treatment. And they said, well, this is our data on our diabetic patients, and we know X, Y, and Z. And they said, so where's your evidence that you do look after your patients very well? And he said, well, all I could say was that I just know I do. And I think it's a growing realisation. I mean, if you've got the interesting thing with the New Zealand system where you actually know your denominator and you can actually start looking at your populations and you can actually do interventions that are very much focused on the individual needs. So in Australia, we've moved to voluntary registration of Aboriginal and Torres Strait Islander people under the Closing the Gap arrangements, which I think is interesting because I always thought that would be the hardest bit to tackle, and it's gone through reasonably well. I do think that there is a movement in that direction. I mean, patient-centred medical homes do require that accountability, that long-term relationship between a general practice and an individual or a family. So I do think that we're moving in that direction, and I think it's important because if you think about where we need to get to, if you look at, say, what a health fund would do with its population, what the public sector isn't so good at. I mean, health funds know their members. They know that 1% of their members makes up 40% of their costs. So they target their interventions for that 1% about how they go about doing case management or telephone support or care coordination or whatever it might be. They look at their next 10% who are the ones who are potentially likely to move into that 1% bracket, and they say, well, what interventions have we got to do with them? There might be others who've got a large number of modifiable risk factors, and so therefore we might do some lifestyle coaching with them. And then there are others who really need population-wide health promotion services, and so we make those services available. Health funds aren't all that good at it yet. They're pretty good they're getting better and better on the 1%. They're not so good at all the rest, and a lot of that's individual choice. They choose not to get involved in lifestyle modification programs, etc. But until we're actually able to use that sort of information more broadly across Australia, then it's going to be very hard for us to do those interventions, because we do need to actually be able to stratify our populations, and always remembering that populations are made up of individuals, and you need to obviously cater your services to meet the needs of those individuals, depending on a whole range of factors. So it's very important that I think that we move to a system where we are much more data rich and are able at a very local level to identify the needs of populations and respond to those needs. Very much a focus about building up the evidence, using quality and safety, I mean, taking all those things into account and, as I say, identifying what interventions need to be done. In addition to that, we need to look at our building blocks, and I've mentioned workforce, so there was a mention earlier, I think, of funding models, and again, we've got a very strongly fee-for-service model for general practice, but in Australia generally, we've got a lot of blended payments in relation to the way we fund state services, federal services and so forth. fee-for-service arrangements largely developed over that focus on episodic care. As our disease pattern changes and our models of care change, then we need to look at new funding models that are better placed to align our resources to achieve the outcomes that we want to achieve. So funding models and alignment of incentives is going to be very important. I've mentioned data and information, technology, communication, etc. And we also need to measure and report on performance. I mean, what tends to drive performance is both financial but also information and knowledge. I mean, focusing particularly on the issue of putting research into, or translating research into policy and action. I'll let you into on a secret. GPs don't usually read 600-page guidelines. They have enough trouble with standards. You need to do things that are actually relevant to them. And I think a good example of that is what's happened through the Australian Primary Care Collaboratives, where you've had 1,100 practices across the country engaged in looking at continuous improvement, Plan, Do, Study, Act processes, where they have demonstrated considerable improvement in the care and the quality of care being provided to a large number of patients, some several 100,000 patients, in areas such as diabetes, chronic disease management, access to services, COPD and so forth. So it's where you actually see the ability to engage, and I think the discussion and Catherine's points about clinical science are very good ones. I mean, if you're going to actually do translation of research, a lot of it actually happens locally, and that's a good thing. We then need to have the ability to spread that good practice out around the country. The NHMRC has a role there, as do Medicare locals, as do local hospital networks and so forth. And I think you should take that opportunity. If you think about, the empowerment of local hospital networks and Medicare locals, that's where a lot of the action will be happening. And there should be a real interest in actually what works, because as we know, I mean, poor practice is actually waste, and there's a lot of financial pressure on. In terms of the hothouse that's Canberra, I think it's just worth mentioning how we operate, or don't, at times. You really do need to understand, I suppose, when you look at the research approach that sometimes takes a long period of time, that the pace of decision making is actually speeding up in Australia. And a lot of it's to do with the sort of 24-hour media, and ministers are supposed to be instant experts and make immediate decisions on things. You would be probably very surprised about, well, you shouldn't be surprised. If you think about the complexity of what we deal with at a national level across the whole range of services, and not just in healthcare, but across all of the portfolios, cabinet decisions are made very quickly. You've got a very short time to pitch. It's a really interesting process about how quickly can you get a grab and actually get people interested in doing something. So it's a really quick translational process that we're talking about. And I think in a sense you need to think about it like change management. I mean, if you think about change management, I mean, what's your burning platform? What are you actually trying to achieve? So have you defined the problem, and therefore have you come up with a solution that is actually easily understood? Do you have a coalition of support? If you're going to have something that people are going to be arguing about, then they'll just not bother with it. So it is about getting a coalition of support who are going to stand up and say, yes, we support this, this is the right way to go, and we'll be vocally in support of it. When the odd, 4 or 5 or 10% of people come out and say, no, we don't agree with that. So where is the voices that are going to support government to make changes? Think about retail, the retail approach. You're trying to sell a product at the end of the day, and your audience may be private providers, they may be consumers, it may be both. I mean, how are you marketing it? What are your channels? What's the way you're going to present what you're doing, the quick grab, as I say, because the timing often at a national level and probably at a state level is fairly short. But if you've got a body of evidence, you've got a strong reason in terms of the pitch that you're making, and the coalition of support that will stand up and support governments when they make decisions, which sometimes are very hard, then you're obviously you've got an advantage there. We do work, just to wrap up, I suppose, we do work, we always have worked in a system of scarcity, and that's why decisions have to be made about priorities. The scarcity is going to be harder and harder over the next few years, but I think one of the attractions about scarcity is that when times are good, then governments tend to throw money at things, even though economically that might not be a good move. When times are hard, you need to think, and you do actually, and that's when ideas are important. That's when evidence and research should more and more come to the fore, because we are facing a period of very severe scarcity. We're in a fairly good position compared to other nations, but it is going to be very important. A lot of people have looked at the reforms that have occurred in healthcare, and lots of people can identify problems and probably not so many identify solutions. I think my point on it always would be that the health system's ever changing. What we've put in place now is going to be different to what's in place in 10 years. You should always look at this as opportunity, and I think there is a huge opportunity here. I think, again, reflecting on what Warwick was saying, the timing of this announcement or the launch today, very important, I think, in relation to the opportunity that exists as part of the overall health reforms. Thank you.